This was a child who had come to me at 7 years of age with rapid weight gain. So again, the same history. There was infantile hypotonia. The child was growing not well, and he was already 42 kg. So the BMI was pretty much high at that point of time. He had that typical features. There was hyperphagia, developmental delay, behavioral abnormality. So this is something which is also very common, that behavioral abnormality will be important. Now, basic workup was normal, and child actually had classical features of Prader-Willi syndrome. And I'm not showing the face here, but they had all the classical features. So this was diagnosed at 7 years of age with these problems. So what would you like to do at this point of time, Vibha, if you diagnose somebody at 7 years?
So at the 7 year of age, we should assess what the pivotal status of the child for the management purpose.
Yes.
Regarding obesity, weight control, dietary, and
the height is also less. So if you look at FDA recommendation, we talk about obesity with growth failure. The general consensus is that any child with Prader-Willi will improve on growth hormone, even if they don't have growth failure, because they will ultimately have growth failure. So we at this point of time advised him that he should go ahead and FISH study. At that time, it was like 15 years ago, we wrote a FISH, it was positive for Prader-Willi syndrome, was advised growth hormone. But the problem was this child did not take growth hormone. Now he came 10 years later on with a weight of around 125 kgs and had developed frank type 2 diabetes. So this was a scenario where we could have prevented this complication from happening if we had given right treatment, right assessment and management at that time. That's why early diagnosis is an important phenomenon. The other basic issue is the challenge of diagnosis. Now, what we often see is that the tests we routinely do, FISH, methylation, even other PCR, often the results are negative. So that is a very confusing scenario. So this we'll be discussing specifically. Naveen will focus about that in that detail. So this is an interesting thing. So Prader-Willi syndrome overall is common, 1 in 15 to 20,000 live births. It may be missed because many milder cases may not be missed, like we missed Turner syndrome also. In that perspective, an early intervention is essential in that setting. It's basically a methylation defect, and we'll discuss in detail about what imprinting, methylation, all those things are in that regards. All of you can have a look at our website, learning.growsociety.in, which has got a lot of innovative tools for training in pediatric endocrinology, along with courses, fellowships, and diploma courses. We run 3 modules in the form of grand rounds as well as postgraduate lecture series every month, which you can access through, along with our publications and the mobile application which is there. So today we are going to talk about a specific topic, and we'll use only one case. Normally we have a spectrum of case, but this case actually in itself had all the findings. So this was a very good case which we managed recently with the pediatric unit in the intensive care. The key challenges that an endocrinologist faces in Prader-Willi are 3. One is obesity and metabolic complications, second is growth, and third is puberty. So Dr. Sain will focus about these aspects. How do we go forward on that?
So the 3 main branches of managing a Prader-Willi child is we manage during early infancy. What are the phases of managing a child during early infancy, coming forward to late infancy and childhood, and thereby going forward to adolescence. So these are the 3 phases which I will describe henceforth. So this is a chart which I would like to show you, because as already told by my previous speakers, that a child of Prader-Willi initially has a phase of failure to thrive, thereafter going into a phase of obesity. So how does this occur? So initially after birth, the child fails to thrive. This is specifically in early infancy. Thereafter, the child grows normally according to the centiles, but further away from it. This phase occurs late in infancy. Thereafter, the phase 2A, the child without increasing his food intake crosses percentiles. So this is the phase which we need to be wary about. This is the phase why we need to diagnose these children early and sensitize his parents, because if we don't check his weight gain from here, he'll shoot off. And this is why I have presented to you this chart. The next phase, the child becomes obese. And further on, the classical Prader-Willi child, which we see in 3 to 15 years of age, the BMI typically shoots off. And if you remember the BMI chart which Dr. Manoj showed, his BMI was sky high. From here on, I would just like to show you a chart in the for the amount of food intake a normal child and a Prader-Willi child takes in. Left side shows normal children who consume sandwiches over 1 hour. So you can see after consuming around 30 sandwiches, they are satiated. But the Prader-Willi child goes on eating, and even on touching a century, he is still not satiated.
So normal child is 30 sandwiches.
No, sir. 30, so it is 30 quarters of sandwich. So it is 3 times more intake, and the calorie intake which a Prader-Willi child can have at a single go is around 1750 calories. So henceforth, the main issues to manage during early infancy are hypotonia and poor feeding. So what do we do in case of hypotonia? The main thing to look forward at this point of time is the strengthening exercises, starting with neck, head control, thereafter the muscles of the back. For poor feeding, we generally take the help of a dietitian. They prefer thickened high-calorie feeds in most cases. Rarest of situations will the dietitian tell us to give tube feeds. Now, tube feeds generally have one more problem, is that speech delay can further be accentuated if you feed this child with tubes. So generally concentrate on thickened high-calorie feeds. Coming forward to late infancy, this is where the obesity factor kicks in. Along with obesity, because development has already been delayed, we also need to focus on growth and developmental issues in late infancy and childhood. So for obesity, as I just showed you, the main factor is prevention. Once the obesity kicks off, because these children have very low expenditure of energy, you can't cut down on the amount of BMI that the child has already accumulated at around 10 to 12 years of age. So prevention is the key. Next, in case of growth and development, we need to focus on growth hormone therapy and behavioral counseling. Now, this counseling is mainly initially for the parents. When a diagnosis of Prader-Willi syndrome has been made, we need to sensitize his parents, his extended family, his school, and all his friends. Thus, these children have a different form of intake and expenditure. Finally, speech therapy also has to be concentrated upon, because without speech therapy, these children have speech onset at around 3 years of age, specifically to be 37 months. As I just mentioned, obesity management is preventive. You need to start very early, because once the hyperphagia and the behavioral disturbances kick in, you cannot control this child. So if the parents counsel the child from the initial phase that you need to have this much amount at this time of the day, they are generally well controlled. And you can go and see the videos of Prader-Willi Association Ireland and International Prader-Willi Association. There you will find extensive videos describing how diet is controlled in these children when started very early. Almost they are normal, just they will show specific increased interest in food, not the specific hyperphagic behavior which you see in late diagnosis cases. Next, low calories. So what is the amount of low calories we need to recommend? As Viva said, it is around 60%, but 60% is generally after 3 years of age. Before 3 years of age, it is generally 80%, because it has been seen very low calorie diet impairs brain myelination. Finally, surveillance part is always for Prader-Willi children, more so in cases late diagnosed. Surveillance for stealing behavior, stealing money, stealing food, keeping them in specific areas where they can consume when the parents are not there. Restriction of access again kicks in when these typical behavior has come in. And finally, behavioral counseling, as I already told you, for the parents, and when such behavior has developed, for the Prader-Willi child. Now, as Sir said, the main pathophysiology is of the imbalance between orexigenic and the anorexic pathways. So the orexigenic pathway is controlled via ghrelin, which increases hunger. And it has been specifically seen in Prader-Willi children that the hypothalamic oxytocin neurons are decreased in number. And it also has been found that oxytocin neurons have an anorexic signal. So ghrelin increases and oxytocin decreases in these children. So this is where the thought process of controlling obesity via drugs came in, starting off with the research in 2004 of somatostatin infusion to lower ghrelin levels and thereafter see the effects on obesity. Somatostatin infusion definitely decreased the ghrelin levels, but was not satisfactory in terms of outcomes of BMI and the hyperphagic behavior. Next, they went on to see that somatostatin infusion couldn't do it. Can long-acting somatostatin analogs do it? So they tried the same with octreotide injections every 4 weekly for 16 weeks. Again, this was unsuccessful. Thirdly, they went on to see two components of ghrelin which are generally there in the body. One, the acetylated, the second, the unacetylated. So what does the unacetylated fragment do? The unacetylated fragment counters the acetylated fragment and thereby decreases hunger. It has been specifically seen that acetylated ghrelin is decreased in Prader-Willi children. So this study published in 2018 was a phase 3 trial, and it did show effects in terms of reducing hyperphagic behavior. For further studies are needed to confirm. As of now, this drug hasn't been approved. Now, coming on to the anorexic pathway, oxytocin treatment in children with Prader-Willi. Oxytocin has been given in these children for a duration of 5 days intranasally. And again, this effect has shown two things. One is decrease in hyperphagic behavior. Second is the behavioral issues tend to increase, tend to become better. One, oxytocin is a short-acting drug. So the next step they did was they brought in carbetocin. Carbetocin, they did studies of 3.2 milligram versus 9.6 milligram. And this study was published just last year. They found that carbetocin definitely improved the hyperphagic behavior, and also the behavioral symptoms became less. But still, it hasn't been approved and is in phase 3 trial. This drug, the MET AP2 inhibition, this study was published in 2017. This showed us that MET AP2, the drug name is, sorry, I forgot it is BET. Huh? No. This is so via this inhibition, it decreases the adipocyte synthesis and also increases the energy expenditure. In spite of all these drugs, none have been recommended for any Prader-Willi child till date. So what is the most common drug given to all Prader-Willi children? This is the drug we all know about. Now let us see what are the benefits of GH when given in a child with Prader-Willi. The first one, which I have highlighted, Prader-Willi child given GH decreases the percentage of body fat, and this reason was also told us to because GH increases lipolysis, decreases body fat. Second, it increases the lean body mass. Now, this is very important. The earlier you start a Prader-Willi child on growth hormone, his lean body mass increases, hypotonia decreases, development accentuates. So the earlier you start a Prader-Willi child on growth hormone, the better in terms of his development. Second, so this was the first paper was of early treatment. Second is of prolonged treatment. Now, Prader-Willi children given 8 years of growth hormone. Now see the findings. BMI SDS significantly lower at 8 years. And what is the outcome in terms of height? Height SDS, head circumference, all normalized. So two things. Start early and give a prolonged duration of therapy. Now the third thing. The third, which I already showed you in the first paper, is in terms of muscle strength. As the muscle strength increases, all developmental parameters will normalize. So again, start early, give for a prolonged duration of time. Now, how do we give growth hormone therapy? All children with Prader-Willi and growth failure need to be given growth hormone. Now, the question comes in less than 2 years, if the child isn't failing to thrive, failing to grow, what shall we do then? In certain situations, it has been seen even in a child with Prader-Willi and normal height, when a dynamic test is performed, they have subnormal responses, and thereafter the child is started on growth hormone. Before starting on growth hormone, we need to exclude certain contraindications, which I'll come to next. Age at initiation. Now, age at initiation very early, before the onset of obesity, so generally very early, 2 to 3 years. Now, what is the dose at which I start? I generally start at a lower dose of 0.5 milligram per meter square per day. So why low dose? Because IGF-1 has been linked to adverse effects of GH therapy in these children. What does IGF-1 do in these children? IGF-1 increases the lymphoid growth and thereby accentuates the sleep apnea and the early onset of death. So start at a low dose, monitor IGF-1 levels, repeat polysomnography, and thereafter increase the dose to 1 milligram per meter squared per day. Now, how do I increase the dose to 1 milligram? It is generally over a duration of 3 to 6 months. But even when not increasing the dose, always tell a child of Prader-Willi on growth hormone to specifically monitor for sleep apnea symptoms. And if sleep apnea symptoms are there, you can ask the mother to put pulse oximetry and check the oxygen levels as well. Moving forward to the contraindications, one, as already my previous speakers has said, is severe obesity. Again, why? Severe obesity with growth hormone increases chances of sudden death. Uncontrolled diabetes. If a child of uncontrolled diabetes is starting out growth hormone, the parameters grow haywire. Any active cancer or psychosis, that is same for all. Again, acute respiratory infection at starting. Again, the symptoms of further respiratory obstruction and sudden death. But
this child has a BMI of 41.
Yes, sir.
HbA1c of 7.4 and had an infection. So what do you think?
So not, I won't start at this point, as Manoj said, we will follow.
We started after the diabetes section.
You have to look at sleep apnea. You have to correct that before this time.
Finally, as Sir just mentioned, untreated severe sleep apnea. This child at 7.9 with desaturations. So now early infancy, late infancy and childhood, I move forward to adolescence. This has already been discussed. Again, what is the main thing affecting an adolescent child? As shown by this study, all males. All males have hypogonadism and 93% females have hypogonadism. So hypogonadism is the thing to treat for an adolescent Prader-Willi syndrome, even on growth hormone therapy. Now, are there any specific guidelines for treating hypogonadism in Prader-Willi syndrome? It is the same for all. You decide starting the treatment, but as we do in any child, we start at a low dose. Again, in this case, this is important because if we start on a higher dose, behavioral issues might increase in these children. So start at a low dose, go slow, and thereby see. Now, this also has been told us to by Sir, this is a multidisciplinary management. Who picks up infantile hypotonia right at the onset? It is a neonatologist. Who gives us the diet? Who gives us the dietary management? It is a dietitian. Who is first called for a case of undescended testes? We are also called, but it is generally a pediatric surgeon who is called. Who is called for a micropenis? We are called. Who is called for obesity? Endocrinologist. Who is called for gastrointestinal problems? A gastroenterologist. Who is called for speech problems? A speech therapist. So it is generally a multidisciplinary management with endocrine issues being managed by us, like obesity and its complications, hypogonadism. ENT is specifically called right from the initial infancy with patients having difficulty in swallowing for a swallow study. Pulmonologist for recurrent respiratory tract infections and interpreting the polysomnography findings. Scoliosis and DDH, we call in the orthopedician. Speech therapist is called for speech issues, and a psychiatrist for any issue related to behavioral counseling.
Which is uncontrolled and has got significant obesity. We discussed that you can't use metformin, sulfonylurea, all those are not going to help. So whether there is a role of GLP-1, now there is very limited literature which is available. There was this study of only a few cases. This was like 23 patients who had been given treatment using exenatide or liraglutide. So this was before the oral preparations were available. What they really found out was that there was some improvement as far as HbA1c is concerned, and there was benefit, but this is a very, very early stage. But if you talk about from a clinical perspective, you have a child who is obese, who has got type 2 diabetes, GLP-1 receptor analog will be a logical choice. What could be a problem of using GLP-1 receptor analogs in this case?
Sir, they don't have, they have satiety problems. So if they overeat and if we give the GLP-1 analog, the stomach distension or rupture can be occurred. Or there is more chances of the reflux disease will be there.
So satiety anyway will come down with GLP-1. So the problem is that gastric motility will come down. So if your gastric motility come down and you are eating, then that could be a big problem. They already may have a gastric obstruction. So it is very good because satiety is coming down, which is good. But gastric emptying problem may cause a problem in that. But this is something we are planning to consider semaglutide in this situation, and let's see how it goes. Because this child otherwise is hugely obese. We have to consider other options. The other option, of course, is bariatric surgery. People have used bariatric surgery, but again, the complications of bariatric surgery are more in Prader-Willi. Benefits are less compared to adolescents with obesity. So again, bariatric surgery is difficult. So overall, if you reach that particular situation where you have a vicious cycle, it is very difficult to manage Prader-Willi. The key message basically of all this talk is that there are clinical features which are available if you can diagnose them at the right time, using the right genetic tool, assess them, prevent the development of obesity. That is the best way forward. Start growth hormone at the right time. If you do it at the late stage, like this child, it is already quite late in that perspective, because diabetes is there, growth hormone will increase the sugars. Definitely, that is what we'll see. So time is major part. You have to identify, evaluate, and manage. That's the most important thing. So anybody who has got antenatal features of hypotonia, persistent infantile hypotonia, along with that there is hyperphagia, rapid weight gain, consider Prader-Willi syndrome. Best is to exclude using a methylation MLPA study, as Dr. Naveen was talking about. Then follow up with complications, look for thyroid profile, adrenal, polysomnography, evaluate and consider growth hormone therapy, because now indications are even if the growth is normal, you can consider if you have a genetically proven. That is the FDA recommendation, which talks about short stature and obesity. But other recommendations, the Prader-Willi societies recommend that you can actually, it will be benefit in other aspects, and growth hormone is a good drug. If you already have developed diabetes, then growth hormone becomes difficult. In that scenario, maybe GLP-1 receptor analog is the best bet as far as management is concerned. Otherwise, insulin again is there. Now, this case is unfortunate. We have got all the history which was there, identified at a very late stage. But even after identification, they were being treated via adult diabetologists with glimepiride, with metformin, with sulfonylureas, with DPP-4 inhibitors. So it was actually a lot of time was wasted at that point of time as well. So again, a big message: early identification, multidisciplinary team, evaluation management is essential. A website along with our other rundowns and books and applications. Scenario, SNRPN gene. Dr. Fahimida Zabin from Bangladesh, one of mine, 8.5-year-old girl with morbid obesity and diabetes on oral and insulin, also diagnosed with leptin deficiency abroad. Is there currently available treatment to address a leptin deficiency? So leptin treatment is available, recombinant leptin is available, but it's very, very expensive and not routinely available. So special programs are there through which it can be there, but again, very difficult to identify. How much does MLPA cost? 8,000 rupees, I think, is the cost. So it's a good investigation. We have been struggling a lot with regards to many classical features of Prader-Willi being missed. So maybe this could be a way forward to identify. Dr. Rajib is asking why growth hormone stimulation test is not done in Prader-Willi syndrome. It is not required because anyway, they will have growth hormone deficiency. If you want, you can do it, but it is not required. It's more of a pharmacological treatment. Is there any specific advice of parent to prevent dental caries? It's the usual measures, basically in terms of the intake, in terms of other routine care, which is important, but there is hypoplasia, so they will be at risk of caries, which is there. In the chat also, there are some questions. The cost of methylation study, again, 8,000 is what's there. Dr. Satyakara is asking how early can we start GH therapy in infancy? Generally, I would be a bit wary about infancy. There are some studies which are talking about, most people talk about 2 years as an appropriate age to start growth hormones. So it will be 2 years will be appropriate, I would say, not infancy. Dr. Satyakala is taking comment I would like to make is that aim for half the weight gain of a healthy infant while we are dealing with feeding issues in infancy. There can be a tendency to aim for weight gain as a healthy infant without Prader-Willi syndrome. That's a very, very important point, that we should not target a rapid weight gain, because the problem is that they have failure to thrive. They are not gaining weight. And then all of a sudden you are targeting more weight and then you go the other way around. So you need to have a preemptive strategy of not allowing that much weight gain. So that's the problem. The more fat that is there in the body, you will have greater amount of appetite which is there. So it's like a vicious circle which happens. So that's why you have to be cautious in that regards. Do you use any nomogram for penile length in children? There are definite references which are available. There are charts which are available. We can share you, Dr. Pankaj, on that.